Okay, Bismillahirrahmanirrahim. Assalamu alaikum and good morning. We welcome everybody to the 12th CPC of Dermatology hosted by Dow International, Dow University of Health Sciences. We are glad for all those who can join us today for this academic activity, which will be beneficial for everyone, inshallah. So we will begin with our first case today, which will be presented by Dr. Sania. And without further delay, we will proceed with this. Yes, Dr. Sania. Assalamu alaikum. My name is Dr. Sania Imtiaz. I'm FCPS resident dermatology at Dow University Hospital, Ojha. I'm going to start today's CPC with our first case of 17-year-old girl, unmarried, no known comorbid, resident of Miawali, came to our OPD on 2nd of April 2022. With presenting complaint of multiple itchy skin-colored lesion on dorsum of hands and feet for last 9 years, itchy lesions over axilla, umbilicus, face and trunk for 2 months. According to the patient, she was all right 9 years back. Then she developed small skin-colored papules over the dorsum of hands and feet. They first appeared on hands bilaterally and then on the foot and extending up to the mid-shins. Initially, they were few in number and with time, they were increasing and never disappeared. The lesions were itchy but not painful. There was no history of any discharge from these lesions. The lesions aggravated on exposure to sunlight and heat. From the last 2 months, she developed itchy, slightly purplish papules over her axilla, inguinal crease, umbilicus, face, neck, and trunk. The lesions appeared at the site of trauma. There was no history of fever, cough, oral ulcers, alopecia, joint pain, dry eyes, painful eye, weight loss. No history of generalized body redness. In systemic review, all was unremarkable except in the central nervous system, in which there is one episode of loss of consciousness occurred at the age of 8 years that lasted for about 2 minutes in duration. It happened because she was in grief state due to loss of her mother. No history of diplopia, vertigo, dizziness, or headache. Past surgical history unremarkable. Personal history, appetite is decreased, sleep normal, bowel habits maturation normal, weight loss not significant, no any history of addiction. Dermatology life quality of index at the time of presentation is 12. Gynecological history, age of menarche is 13 years, menstrual cycle regular, 7 days every 28 days, no dysmenorrhea or intramenstrual bleeding. Family history, no history of similar lesion in any other family member, no history of any chronic illness runs in the family. Drug history, she took multiple injections for her disease from local clinic, but her condition did not improve. Socioeconomic history, she belongs to a lower middle class family, lives in a rented house, 3 rooms, well ventilated, sanitary hygiene was satisfactory. On examination, before proceeding to examination, I would like to add here, a verbal consent was taken from my patient for her pictures presenting in today's CPCs. Young girl of average built-in height, sitting on chair, well-oriented to time, place, and person. Although she was cooperative, but she was depressed. Vitally, she was stable. Subvitals negative. On cutaneous examination, on hands, multiple small skin-colored flat-top papules were present over dorsa of hands. Few were discrete and few were coalescing. Feet, multiple small skin-colored to brown flat-top papules present over the dorsa of feet and extending up to the mid-shin. Multiple slightly violaceous flat-top papules were present over the axilla, inguinal crease, umbilicus, face, upper chest, back, and abdomen. Few papules were eroded. As you can see in these pictures, and in these pictures, the papules are present over the face, back, and in the axilla. Hyperpigmented macules and patches are present over the forearm. Nail examination. The henna application was done over the fingernails. Cuticle was intact. Leukonychia was present, and splinter hemorrhages were appreciated. There is a V-shaped nick was appreciated on the nail of the middle finger, as you can see in the picture. Web spaces were clear. The nails of feet are irregular with rough edges. Cuticle was intact. Splinter hemorrhages were appreciated, and web spaces were clear. Palms and soles unremarkable. Oral mucosa, nasal mucosa, and scalp examination unremarkable. On palpation, unremarkable. Systemic examination, including chest, abdomen, cardiovascular, and central nervous system, unremarkable. So, case summary, my patient, 17-year-old girl, no known comorbid, presented with the complaint of itchy skin-colored lesion on hands and feet since 9 years, with the development of violaceous lesion in axilla, umbilicus, and trunk from last 2 months. The lesions aggravated in summer. On examination, you can see multiple small skin-colored flat top papules are present over dorsa of hands and feet, and multiple slightly violaceous flat top papules were present over the axilla, inguinal crease, umbilicus, face, upper chest, back, and abdomen. Along with that, hyperpigmented macules and patches are present over the forearm. Nail findings included leukonychia, splinter hemorrhage. V-shaped nick was appreciated on the nail of the middle finger. So after history and clinical examination, our differential diagnosis are diarrhea disease, lichen planus, acrokeratosis verruciformis of Hoff, epidermodysplasia verruciformis, lichen mixed edematous, papular sarcoidosis. To rule out final diagnosis, we go through some baseline investigation that included CBC, which came out to normal, LFTs, also normal, viral markers in thyroid stimulating hormone was also normal. So we go for the skin punch biopsy that was performed from 2 different lesions, as my patient has 2 different clinical presentation of the lesion. This biopsy has been taken from the abdomen, which shows there is, you can see in the left side of the picture, there is marked hyperkeratosis, acanthosis, and with focal parakeratosis. And in the right side, you can appreciate there is an intraepidermal blister, which is supravasal and it containing few acantholytic cells. Cells are surrounded by a clear halo, that pycnotic cells are surrounded by a clear halo, which is suggestive of corp and drum. This biopsy has been taken from the feet lesion, foot lesion. It shows there is marked hyperkeratosis, acanthosis, papillomatosis, and the elevation of the epidermis suggestive, resembling the chart spire pattern, as you can appreciate it in this picture. After the investigation and the biopsy, our final diagnosis is coexistence of diarrhea disease along with acrokeratosis verruciformis of Hoff. Management plan: a detailed counseling regarding the disease was done to the patient and her family. And as my patient has 1 episode of loss of consciousness and the disease is associated with neuropsychiatric complication, and she was also depressive, so we took a neurology and psychiatric review, and they advises the EEG, which came out to normal. Our plan to start on oral retinoids. For this, we go for screening lab test workup, which comprises of CBC, which is normal, fasting lipid profile, also normal, LFTs, normal. Capsule isotretinoin 20 mg twice a day was started. Dosage was calculated according to the weight of the patient. As the drug of choice in the diarrhea disease is acitretin, but the contraception period of acitretin after stopping the drug is 2 years. And our patient is young age and fertile age group. So we started isotretinoin, which is a shortest period of contraception, around 1 month. Adapalene cream daily in night on hands and feet. Lactic acid plus 2.5% hydrocortisone lotion mixed with moisturizing on body once in a day. Tablet Epstein 20 mg once in a day. Tablet amitriptyline 25 mg once daily after taking neurology and psychiatric review. Cryotherapy was advised and was done on the lesions of hands and feet. 2 sessions were performed. Moisturizing soap. These are the follow-up pictures of 3 months and 6 months, which clearly showing a significant improvement, and the thickness of the lesions has been reduced, and the rest of the body lesions are completely dissolved, as you can appreciate it in these pictures. Her dermatology life quality of index at the time of presentation was 12. After 3 months, it came out 6, and after 6 months, it was 2. A brief discussion about the disease. Diarrhea disease, it is an autosomal dominant genodermatosis characterized by chronic eruption of keratotic papules, generally of teenage or adult onset, predominantly in seborrheic areas. Men and women equally affected. Gene mutation, ATP2A2 gene mutation. Histology, diarrhea disease, it shows disordered cell adhesion, acantholysis, and differentiation. Clinical features comprises of Keratotic papules that are present predominantly on the seborrheic areas. In the central one picture, as you can appreciate it, some regions are confluent on the ear. And in this right side picture is of the axilla, in which the keratotic papules are present, but they form an irregular warty and fissured plaque. Nail changes, including nail fragility, longitudinal band, white and red band, can also be appreciated in this picture. Pitting of hands can disturb the dermatoglyphics. It also involves the mucosal surface oval cobblestone appearance, with also including the eye findings, chronic blepharitis, dry eye, erosion, corneal erosion can also occur. Acrokeratosis verruciformis, plain wart-like lesion best seen by transverse illumination, commonest on the dorsal hands. Complication, impetiginization, eczematization, increased susceptibility to infection with herpes simplex, herpes zoster, cowpox, and pyogenic infection. There is an increased risk of squamous cell carcinoma and Paget's disease. Neuropsychiatric complication involves depression, bipolar disorder, epilepsy, intellectual difficulties. Disease course and prognosis, it is a chronic relapsing course with unpredictable severity. It can both improve and deteriorate in old age. Treatment ladder comprises of first line, second line, third line. First line, emollients and topical steroids, avoid excess heat. Second line, moderate potent topical steroids, along with combination of oral antifungal, antiviral, or antibacterial, depending upon the superimposed infection. And the chronic disease treatment of drug is oral acitretin 0.25 to 0.5 mg per kg or isotretinoin 0.5 mg per kg per day. Third line comprises of topical 5-fluorouracil cream, topical tacrolimus, topical T-calcitol, oral alitretin, photodynamic therapy, surgical or physical therapies for flexural disease, breast reduction, and botulinum toxin. Here is the case report in which there is a coexistence of diarrhea disease and acrokeratosis verruciformis of Hoff, similar to my patient. A 31-year-old woman presented with evaluation of papules on her face, scalp, neck, dorsa of hands, axillary, and inframammary regions, and dorsal surfaces of feet. We go for skin biopsies were taken from two different sides, as same in my patient. That biopsy taken from the neck, it shows suggestive of the diarrhea disease, and the biopsy that is taken from the foot lesion, they shows the church spire pattern suggestive of acrokeratosis verruciformis of Hoff. This is another case report of Indian Journal in which there is an age similar to my patient, 17-year-old adolescent male presented with generalized pleuritic eruption for last 3 months, started from the neck, later progresses to involve over her face and trunk. The lesions also appear on dorsum of bilateral hands and feet. Biopsy were taken from two different lesions that were suggestive of diarrhea disease and acrokeratosis verruciformis of Hoff. I'm going to end my case by having picture of my patient smiling on her face. She remained undiagnosed since many years, despite being visited many hospitals and clinics. She came here, we made a diagnosis, put her on a treatment that make her smile happy. And so the aim of the doctor is to not only to treat the disease, but also to improve the quality of the life of a patient. Thank you. Okay. Thank you, Dr. Sania. Thank you for a comprehensive presentation. That was indeed a smile of a happy person. Now, diarrhea disease is a rare disease, but we have read and we have seen a spectrum of varied presentations. A proper history and a good examination is the key which points in the right direction of a correct diagnosis. These two factors alone are so significant when they are performed properly, they outline a picture of the condition very, very clearly. However, wherever in doubt or when it's not clear, the other tools such as investigations can be used to fill in the pieces. Now, being a genetic condition, it lasts indefinitely, and it has significant physical impact as well as grave psychological impact. This patient had been suffering from 8 years of age. She was depressed in the sense that she could not stop tearing up the first time she came to us. She was socially withdrawn. People were reluctant to invite her at gatherings, and some considered her a bad omen as well. So moving from that point, establishing a diagnosis, explaining her what her disease was, addressing all her queries, guiding her through the process of the treatment, of what to expect and what not to, and then All this process gave her hope for improvement. And she was very cooperative with us throughout this process, and we saw her improve physically as well as psychologically, mentally. Her social skills became more enhanced. She became confident. Her self-esteem was increased, and she was happy. All smiles, and that smile is our achievement. We will proceed with the next case, and we will take all the comments and the questions towards the end. Okay, thank you. Let's begin with the next case. Assalamu alaikum. I am Dr. Irajaman, FCPS resident in dermatology at BUHS Ojha. I am going to present a case of 13-year-old female who is resident of Karachi, a student with no known comorbs, presented to us in OPD on 21st of May 2022. She has a presenting complaint of loss of body hair since 1 year and ulcer on right foot since 1 week. Now coming to the detail of presenting complaint. According to my patient, she was all right 1 year back when she started noticing diffuse thinning of her body hair. The thinning was started from her leg, then progressed to involve her trunk, arm, and face, resulting in complete hair loss from the body. There was no associated itching. There was sparing of scalp, pubic, and axillary hair. She also noticed puffiness of hands and feet few months after the hair loss. It was mild and was not restricting any of her daily routine activities. There is no history of any associated difficulty in swallowing, joint pain, muscle pain, bluish discoloration of fingers, loss of sensation, decreased power, decreased sweating, any hoarseness of voice, any recent febrile illness or photosensitivity. Although she was complaining of ulcer on right foot since 1 week. Initially, the ulcer started as a small bulla, which was filled with clear fluid. It ruptured spontaneously and then left a superficial ulceration. The ulcer was painless and it was non-discharging, and there was no history of any trauma at that time. Her systemic review was unremarkable, except that she was having intermittent episodes of bloody discharge from her nose on and off since 1 year. The discharge was 2 to 3 drops at a time, and it occurs once or twice in a month. In her past medical history, it was significant for multiple painful nodules over the extremities and trunk 1 year back, which then resolved spontaneously and they never recurred again. Her past surgical history was insignificant. Her personal history, her appetite and sleep was normal, bowel habit and maturation was also normal. She was not having any significant weight loss, and there was no history of any addiction as well. She is starting having menstruation at the age of 12 year, having regular cycle of 7 days occur every 23rd day, having normal flow with intermittent episodes of dysmenorrhea. There is no episode of any instrumental bleeding. In her family history, there is no history of any similar disease or any chronic illness in her family members. Her travel history was significant for immigration from Bajor Agency, KPK. She came to Karachi 2 to 3 years back along with her family. Her drug, allergy, and transfusion history was not significant. In socioeconomic history, she belongs to lower middle class family. They live in a rented house of 2 rooms, which was well ventilated, sanitary condition was satisfactory, and she was fairly dependent on her father for living, who is the sole breadwinner of family. Before proceeding towards the examination, I would like to inform you all that all the pictures of my patient were taken with the consent of her father. Now, starting with the general physical examination, my patient is a young female of average height and build, sitting comfortably on the chair, well oriented to time, place, and person. She was vitally stable and all her subvitals were negative, except she was having bilateral pedal pitting edema and up till mid-chin. Her thyroid and lymph nodes were not palpable. In the cutaneous examination on face, she was having bilateral thinning of eyebrows with patchy hair loss of medial 1/3 of eyebrows, as you can clearly see in this picture. On arms, legs, and trunk, skin was shiny and there was generalized hair loss. There was also an erythematous net-like pattern present over the skin of both the upper and lower limb. On this slide, you can see the erythematous net-like pattern present on the legs.
as well as the skin was shiny and there is hair loss. The next slide is showing erythematous net-like pattern over the forearm as well. Her hands were puffy, skin of the hand was shiny and taut, and there was mild skin thickening on both the palmar and dorsal sides of hands. There was mild limitation in pinching the skin. Feet were edematous with dry and taut skin. There were two superficial ulcers present on the dorsal of right foot. One was located on the second and third toe, extending up to the metatarsophalangeal joint. The base of the ulcer was erythematous and it was covered with yellowish-brown crust. The margin of the ulcer were irregular with surrounding erythema. It is of size of 2 into 2 centimeter. The ulcer was non-tender and the sensation were impure. There was another ulcer of similar description present over the medial arch of foot. It was of size of 3 into 2 centimeter. Prayer sign was done in which we asked the patient to approximate the palmar surface of both the hands and it was not restricted. Mouth opening was also not restricted. Examination of the axillary and pubic hair, oral cavity, nasal mucosa, scalp and nails were all unremarkable. Now coming to the CNS examination, my patient's GCS was 15 by 15, her higher mental function and speech was intact, all her cranial nerves were also intact. Motor system examination was unremarkable. Coming to the sensory nerve examination, there was reduced light touch, pain, temperature sensation on dorsal surface of the hands and feet bilaterally in a glove stocking pattern. On examination of peripheral nerve, there is a firm cord-like thickening of ulnar, radial, superficial peroneal nerve bilaterally without any tenderness or any deformity. Peripheral vascular examination doesn't show any change in the skin color, any temperature difference, or peripheral pulses were palpable and normal throughout both the upper and lower. Systemic examination, including the respiratory, abdominal, and CVS, all were unremarkable. Musculoskeletal examination doesn't show any swelling, bruising, angulation, deformity, muscle wasting, any bony tenderness, or change in the range of motion. Eye examination was also done and it was unremarkable. Now the case summary of my 13-year-old female patient. She has no known tumor, presented with the complaint of loss of body hair since 1 year, an ulcer on right foot since 1 year. On examination, she has bilateral thinning of eyebrows with patchy hair loss of medial 1/3 of eyebrow. Hands were puffy and skin of the hand were taut and shiny. There was mild skin thickening on both the palmar and dorsum aspect of the hands and legs, along with the bilateral pitting pedal edema. There were two superficial ulcers present on the dorsum of right foot, which were non-tender and sensation were impaired in glove and stocking pattern. Libido reticularis pattern was also evident over the limbs, and peripheral nerve examination showed thickened ulnar, radial, and superficial peroneal nerve bilateral. Now, after the complete history and detailed examination, we made a list of closest and strongest differential diagnosis depending upon the feature of our patient. The top one is leprosy, as we are living in a region where the leprosy is endemic, as well as the childhood leprosy is prevalent in Pakistan. And many of the features of my patients were similar to the leprosy presentation, like she was having edema, she has history of ulcer, she has history of hair loss and libido reticularis pattern. And there was also thickened nerve palpable on examination. The second differential was mixed edema. Mixed edema we kept because of the presence of pedal edema and the thickening of the skin of the upper and lower. The next was scleroderma. Scleroderma because of the thickening of the dorsal and palmar surface of the hands, as well as the pitting edema and the hair loss. The last differential we kept was vasculitis. And in vasculitis, we kept cutaneous polyarteritis nodosa because of the presence of history of the painful nodules previously 1 year back, as well as the patient was having libido reticularis pattern on the examination and presence of ulcer. We investigate the patient thoroughly. Starting with the baseline, we requested CBC, and the CBC patient was having hypochromic normocytic anemia along with raised ESR of 80 millimeter per hour. UC, random blood sugar, and LFTs were done, which came out to be all within the normal range. Thyroid profile was also done, which was also within the normal range. Her viral marker and ANA profile was also done to rule out autoimmune disorders, and it was negative. Now, after all that blood investigation, we performed a skin punch biopsy on our patient, which showed ulceration in the epidermis and dense neutrophilic infiltrate in the epidermis. There was also a specific snaking pattern of histiocyte seen in the mid and deep dermis. The histiocytic pattern of snaking was seen in around the adnexal structure and blood vessel. And there was no evidence of any vasculitis over the histopathology. Weight fighting stain was also done because we kept leprosy in our differential and it was non-contaminant. And there was no convincing dermal mucin deposition present over the histopathology as well. Immunofluorescence was done and it showed focally positive IgG. Now, up till now, after the comprehensive investigation, we shortlisted the differential diagnosis to the leprosy because of the convincing points toward the leprosy. But to make the diagnosis confirmed, we performed slit skin smear examination and it came out to be positive with a bacillary index of 1.5. So our final diagnosis was made usual leprosy. Before proceeding towards the treatment, we requested glucose 6-phosphate dehydrogenase enzyme and it was not deficient. In management, we counsel the patient in detail regarding the nature of the disease and advise the screening of household contact to break the chain of transmission of leprosy. We advise rest and to avoid shoes with narrow toe cap to prevent further ulceration, and leg elevation was advised. Daily saline wash and dressing along with antiseptic wash once daily was advised. Daily soaking of feet in water for 10 minutes followed by application of white soft paraffin for dry skin, and then patient was referred to the leprosy center for the provision of medication, where she was given tablet dapsone 50 mg, clofazimine 150 mg, rifampicin of 450 mg on day 1 once monthly. And from day 2 to 28, she was given dapsone 50 mg once daily and clofazimine 50 mg on alternate. After we gathered the information from the doctor working in the regional leprosy center about the progress of the patient, and the doctor and as well as the father told us that the patient is improving significantly and she is currently on her treatment and soon her treatment is going to complete, and after that she will be kept on close follow-up for next 5 years. Now, leprosy, which is a chronic granulomatous disorder, which is caused by Mycobacterium lepra, and it can affect any tissue, but principally affecting the peripheral nerves and skin. Now, this is an important slide in our case because up till 2021, the data that were provided by the WHO, the active cases of leprosy in Pakistan was 285. Out of those 285 cases, 25 were children, which makes a 8% of all the ratio, and they occur between 0 to 14 years of age. And out of those 25 children, 91% cases where there were history of household contact. In 60% of these, it was a parent, and in parent, the index scale had a history of lepromatous leprosy. Now, clinical presentation, leprosy has wide range of clinical presentation depending on the immunological status, extent of spread, and development of complication. Today, we will discuss lucial leprosy. Lucial leprosy is a diffuse non-nodular type of leprosy. It is also known as lepra bonita, which means beautiful leprosy because of the appearance of patient as shiny skin and mixed edematous appearance, which makes the patient looks pretty. In the clinical feature, initially, the lucio patient have mixed edematous appearance, and after their years later, the patient skin can become atrophic or ecthyosiform. The patient can have history of loss of body hairs, puffy hands. There can be widespread small telangiectasias. Legs ulceration can be present, widespread sensory loss, ulceration of the nasal mucosa, which results in epistasis. Laryngeal involvement can cause hoarseness of voice. Eyes have shiny appearance and there can be thickening of upper eyelid, which gives patients a sleepy look. Unlike the lepromatous leprosy, there will be no specific skin lesion in this type of leprosy. There will be no motor palsies or eyes are not damaged. There is a specific type of phenomena seen in this type of leprosy, which occurs 3 to 4 years after the disease starts. It can occur in the untreated patient as well as in those who are receiving inadequate treatment. It occurs due to the free replication of Mycobacterium leprae in the endothelial cells, which enhance the exposure of antigen to the antibodies, resulting in the vasculitis and infarction development. Clinically, the patient will have painful and tender red patches, mostly on the extremities, and these patches will become purpuric. The center of purpuric lesion will become necrotic or ulcerated, and they will develop brown or black crust. The crust will fall off after a few days and will leave a superficial necrotic scar. All this process will take about 15 to 20 days. The clinical diagnosis of leprosy depends on the three characteristic findings. Two should be present at the time of diagnosis. Number one, anesthesia of the skin lesion. Number two, thickened nerves. And three is typical skin lesion. Or patient can have demonstration of acid-5 bacilli in slit skin smear or histopathology suggestive of leprosy. Now, the treatment of lucial leprosy is similar to the multibacillary multi-drug treatment given for leprosy, but the dosage is slightly different in children. We will today discuss only the dosage in the children. In the children, rifampicin will be given in a dose of 450 milligram, while clofazimine will be given at a dose of 150 milligram, and a tablet dapsone will get in 50 milligram. From day 2 to 28, clofazimine will be given on every alternate day, but dapsone will be given as a daily dose. Some second-line chemotherapeutic agents such as fluoroquinolones, minocycline, and clarithromycin can also be given in cases of resistance. Now, discussion on the literature review. The first case is from the Indian Journal of Dermatology, in which the patient was misled towards the mixed regimental disorder due to the appearance of the patient as dry, xerotic skin. She was having edema and shiny skin. But after referral to the dermatologist, peripheral nerve examination was done, as well as the sensory examination was done, and it showed enlargement of the nerves, as well as the sensation was impaired. Slit skin smear examination, as well as the histopathology was done, and it came out to be suggestive for leprosy. The second case is from the Journal of Brazil of Rheumatology, and they discussed a case where, in this case, a male patient who was diagnosed as a systemic sclerosis for many years because the skin biopsy resulted negative for any leprosy. Years later, he developed hypoaesthetic skin lesion, and then the referral to the dermatologist was made, then further progress was made, and multiple skin biopsy was done, which confirmed the diagnosis of tuberculoid leprosy. So my take-home message for today's case is it is not only important to diagnose a patient to prevent death, but more importantly, it is important to improvise the quality of life of patient. Thank you.
Assalamu alaikum, everyone. Thank you for joining us this morning. I'm Dr. Madiha Sajid. Thank you, Red, for the nice presentation. The case of lucial leprosy is presented for the to refresh our concepts on leprosy and to revisit the topic and understand it better, as it is the most oldest disease which is known to the mankind and afflicting it severely. The lucial leprosy is one of the rare variety we all know. Other than the rare variety of this, histoid and pueril leprosy is also among the rare varieties. When we went through the literature, most of us found mostly the cases of lucial phenomena rather than lucial leprosy. And this thing is well supported in the Joplin, which I'll quote here, which states that the diagnosis of lucial leprosy is easy to be overlooked before the lepra reaction. But once it is suspected, it is easy to diagnose because usually the BR index of the patient is positive. So this case actually demonstrated what is being seen in the literature and our textbooks. Now, this case was actually referred to us from the medical OPD for the workup of a possible autoimmune condition. But as we proceeded with the case, we found that this ended up as a case of lucial leprosy. So this little effort from our side might have saved the child from the going into the lucial phenomena, which is quite lethal and fatal. Here, I would also like to thank the Medu-Adelaide Leprosy Center doctors who continuously help us in following this patient. And we recently also get the update from how the patient is doing. And she is, alhamdulillah, doing well and about to complete her treatment. So this is all from our side, and we'll just be opening everyone to have queries and questions. Thank you.
Okay, if there are any comments or questions, questions is spending. Sorry, questions is spending. Okay.
Yeah.
इधर आते हैं नहीं नहीं ठीक है ठीक है
Yeah, you can unmute and
yeah we can
question.
we've unmuted everybody. Would anybody like to make a comment? We are muted.
Do we have any questions?
Or if anybody would like to make a comment. Are we open for conversation?
Yes, ma'am.
Okay, let's put Dr. Zanaz on line. She was right there. Can we have her voice?
Yeah, Rabia has.
Okay.
Okay, can you listen to me, my voice?
Yes.
Okay, it was a pleasure. Assalamu alaikum, Sadaf and Madiha both. It was a pleasure seeing you both and doing so well. It's always heartening to see my students flourish so well. And both the cases were very well presented. And it was good that you didn't waste time in the interactive session. The only thing is that they went very fast. Like in their speech, because I was finding it difficult to follow. जब वो history बता रहे थे तो जो salient features हैं उसको थोड़ा सा emphasize करके space करके बताना चाहिए so that we can also pick up. For them it's a case which they have prepared and they know they have a command. तो ये है कि वो presentation तुम्हारी भी हमेशा सदा बहुत तेज होती है तो उसको जरा सा slow down करो pace because the students can benefit more. Or the cases were very good. They were very well worked up, and they were something we should think and we never think about. One is Darius disease, the other is leprosy. Leprosy comes into the differential diagnosis of all the conditions. Especially जब आपको patient कहता है ना कि they have been to multiple places, to think outside of the box, which you don't get to see. And the way teaching hospital works is that they should pick up such rare cases and investigate and treat them. So it's very heartening to see, and I must congratulate both the presenters for doing an excellent job and for your department to be looking after the patient in such a comprehensive manner, especially the follow-up, which is really at a loss at most of the places. Because these poor patients, they don't report back because aajkal traveling and everything is so expensive. But then the postgraduates, they follow them, they chase the patient and they keep in touch. And that is very good technique. And you must publish these cases. They must go to the literature. And I must congratulate you once again. Thank you.
Thank you so much, Dr. Manas, for your valuable comments. Okay. Dr. Rabia?
Yes, Dr. Rao.
Yes.
Assalamu alaikum, everyone. I must congratulate the UHS team. The cases were very nice and nicely presented and nicely followed up. Especially the second case, I initially thought of autoimmune and connective tissue, but later the case turned out to be a very rare case. Lucio leprosy is very uncommon in our part of the world, but it is said that it doesn't occur. But I also saw a case, a suspected case of visual leprosy, a old age man with similar findings. But he was in sepsis and expired before we could do further. We sent to leprosy center. His smears came out to be positive, but he expired. So it may be seen in our in India there are a few case reports, but in our country there is no case report, so it must be reported. And as the Dr. Zarna said, that think out of the box. I think this should be the take-home message of today's session. Thank you.
Thank you, Dr. Rabia. Anyone else who would like to comment? Or any query? Is there any?
Assalamu alaikum, Sadaf and Sadaf's team. I'm Dr. Najia. Thank you very much for presenting very well prepared cases, especially as everyone is saying the second case, Lucio, we have not really actually seen. So it's a very rare case and very well presented. And I think all trainees should try to remember this case because I don't know if they would see it again or not because it is very rare. And especially I said it not actually occur in our part. But हमारे यहाँ तो इसलिए disease का पता ही नहीं चलता वही राबिया वाली बात कि हम report ही नहीं करते तो ये आप लोग जरूर report करें. It's a very nice case. Thank you very much.
Okay. Yes, we have all the intentions of reporting both the cases because they're all fully worked out and we have all the requirements. So inshallah, we'll be reporting them soon. You'll see them printed in a journal soon. Okay, so if there are no more comments, then we would like to wrap up by saying thank you to everyone who has shared their precious time with us for your valuable comments, our seniors, juniors, trainees, PAD members, everyone. And a special thanks to Mr. Yasser and the team from Brooks, who have been very cooperative for planning and execution of today's event, along with IT team of DUHS, who worked in liaison together with the Brooks team for a smooth transmission of today's event. And hopefully everything was nice. Okay. So inshallah, we'll keep all the comments in view and all the best. Anything you want to say?
Okay, thank you everyone.
Allah Hafiz. Allah Hafiz. Thank you for joining.